So we're here today with Dr. Divyesh Sejpal, who has a very exciting paper in gastrointestinal endoscopy entitled Improving Patient Safety in the Endoscopy Unit, Utilization of Remote Video Auditing to Improve Timeout Compliance. So Dr. Sejpal, can you tell us a little bit about your work and how you came up with the idea and the execution of the paper and what it says in a nutshell?
Absolutely. First of all, thanks for having me. As part of our quality initiative and looking at improving patient safety, we wanted to assess our timeout compliance rates. And if you look in the surgical literature, there's actually a lot of literature on how doing this timeout process actually reduces surgical adverse events and improves patient outcomes. So back in 2004, CMS actually held the endoscopy units sort of to the same standard as the OR, getting rid of sterile versus non-sterile environments. And then in 2014, the ASGE actually had specific recommendations or guidelines for improving patient safety in the endoscopy unit. And one of those was the timeout compliance, or the TOP, timeout process. And there's not been a lot of attention in the endoscopy literature on this topic. There's no information on the optimal method to perform, to enforce, or comply with this process. So we hypothesized that something called remote video auditing would be an effective tool to evaluate and improve our TOP compliance rates. There's not a lot of information on RVA in healthcare, but it's been used a lot in commercial industries such as meat packing and with other fast food to monitor safety and also efficiency. And it's also been used a little bit in the operating rooms also.
Interesting. Wow. Now I understand there was a run-in component where they were observed and then graded and then found deficiencies and corrected them and implemented it going forward, right?
Absolutely. So, we did it as a single center prospective trial, and what we did is we installed the cameras in all the rooms in endoscopy. And then what we did is over 2 months, we audited all our cases. So there were a total of 692 cases, and our compliance rate was 69.6%, so quite low.
What were the biggest deficiencies amongst the endoscopists and the staff with the timeout?
So that's exactly what we were trying to address. So once we found out that it was that low, a multidisciplinary team, quality team met, including gastroenterologists, nursing, and anesthesia. And we identified barriers to doing this timeout compliance. And then we actually developed actionable items to address those barriers. And then once we implemented this action plan in the entire unit, we actually looked at it again, remeasured it, so post-intervention over a span of 22 months.
Great, tremendous. How was the voice of the endoscopist integrated into the action items?
Yeah, so so interestingly, when we kind of found out after doing the auditing what these barriers were, and a lot of it had to do with these specific barriers. So we identified 4 barriers, and the first one was the lack of leadership. And so sometimes anesthesia would do the timeout, sometimes it was the physician, sometimes it was the nurse, sometimes it didn't happen. So in order to address that specific barrier, we actually designated the anesthesiologist or the nurse anesthetist as the point person, the lead person. The second barrier was basically inconsistent documentation of this timeout process. So we didn't know when it actually started, when it actually ended. So we actually had a cue, a visual card, a yellow card that we would hold up to the camera, and it would initiate when it started and stopped. And then the third barrier we found was basically the checklist wasn't really relevant to endoscopy. There were things on there that talked about DVT prophylaxis, Venodynes, the surgical site, estimated blood loss, sterility, which didn't really apply, so it confused a lot of the doctors. So we actually made an endoscopy-specific checklist.
Perfect. And this has been provided with the paper, so others can use it.
Yes, great. Exactly. It's all in the paper.
It's a nice resource.
Yeah, absolutely. And it even has, and what's interesting is the yellow card is the visual, and behind the card is where the safety checklist is that the anesthesiologist reads. it has the question, and it also has who the responder is supposed to be. And then the last barrier was basically a lack in patient safety culture. So to address that, we basically sent out memos to all the physicians and staff talking about the importance of the timeout process, and also we had specific nursing competencies that were addressed.
Perfect. Perfect. Now, I was quite impressed about the sustainability of the change at your center. You followed the staff and physicians for some time, I understand, afterward.
Yeah, actually, so what we found is right after we implemented these actionable items, the compliance rate went from 69.6% to 95.3%, a rapid rise. And then what we did is we measured it, as you said, over 22 months.
Wow.
And we found a sustained improvement the entire time. So we audited over 12,000 cases.
Wow. Now, were the physicians and the staff, were they aware during the entire audit period that they were on camera, or is it you would come in and out on camera to kind of blind them a little bit?
No, so they knew they were on camera. And the way the camera works, it's low resolution.
I see.
So you can't really see any patient information or anything else. So it's low resolution, and it's encrypted, so it's audited to an off-site place where they keep it for about 24 hours, and then it gets deleted. But all the data we have whenever we want it. And everybody was engaged. That was part of that patient culture safety thing where the anesthesia, nursing, everybody was engaged, and a lot of these same people were part of the multidisciplinary process that we did.
It'd be interesting now to secretly do it, blinding them going forward to see if you're able, how long you can sustain it in the future when they're not aware they're on camera. But
yeah, well, we have the cameras now as part of our OR. So
carrying forward a little bit with this.
Exactly. So one of the other things that we're looking now into is not just this with timeout compliance, but we're actually looking at first case start times.
Tremendous.
We're looking at room turnover rates and even duodenoscope reprocessing.
Very important areas that aren't being addressed in a really scientific way, which you're doing, and it's exciting. Were you able to correlate any issues of, say, medical mistakes or things like that occurred with timeout, or was that not part of this project?
Yeah, so that wasn't part of this project, but it's a good point. It's actually one of the limitations, I would say, of this study because yes, remote video auditing showed us that the compliance rates went up, but we can't really measure the clinical outcome because there's not many mistakes in the first place. So it's really hard to measure that. That would be a different study.
Well, it was really impressive work. I want to congratulate you on the paper
Thank you.
and gastrointestinal endoscopy. We're excited to have it and the implications for our society.
Thank you.